that, being put on the spot like that is what makes you better, right? Because I'll never forget the things that I messed up on when I was there, and I will remember them to this day because you feel this big, right?
Yeah.
So it's an amazing learning experience.
Hello and welcome to the I Give a Damn podcast. I'm your host, Dr. Joseph Allen, and here we keep you up to date on the hottest topics and trends affecting optometry through discussions with the industry's leaders, masters, and entrepreneurs. Made possible through Fluorescene Media, the same company behind ODs on Facebook. Today's guest is none other than Dr. Julie Rodman, and in our discussion we cover hot topics such as retina optometry, the utilization of OCT and OCT-A technology in patient care, as well as academia and the future of residencies. I think this was a fantastic conversation, something I really enjoyed, so please lean in. And here we go with Dr. Julie Rodman. Well, Julie, thank you so much for being our guest here on the podcast, taking time again out of your busy day. We're here bright and early in the morning. You're, I think, the earliest guest we've ever had here on the show. So thank you for just being here.
Thank you so much for having me. I'm super excited that we finally got our schedules together. I feel like we've been trying to schedule this for a long time, so thanks for having me.
Well, Julie, as with all of our guests, I love hearing everybody's story of how they first even found optometry. How did you get through that? Was it part of your family? Did you just have a great experience with an optometrist when you were young? Well, how did you find it?
It's actually an interesting story. I never wore glasses my whole life. I had perfect vision. I did know when I finished undergrad that I wanted to do something in the health professions field. I wanted to help people. My dad's a chiropractor, but I did not want to go into chiropractic. And I also didn't want to do anything invasive. I didn't want to go into the surgical room. I really don't love the sight of blood. So I went to the library. And I found optometry and I said, man, that sounds like something exciting. So I was the last applicant to the New England College of Optometry for the cycle of the year that I was in, and flew to Chicago to take the late OAT exam. Actually did pretty well considering I didn't prepare very much, and got in. And it was like a last minute whim, and it was the best decision I ever made.
That's amazing. Congrats.
Thanks.
It's interesting because it's kind of a little bit of how I made my decision. I had that opportunity, and I'm very grateful that Dr. Mike Sufka was my optometrist growing up. And he had a great impression on me just from fitting me with contacts. But then he suggested, even to me, is like, you should shadow both optometry and shadow ophthalmology to just decide what's going to be better for you. I went into the OR, watched cataract surgery, went just fine, but then I saw blood at one point, and I pretty much passed out.
Oh, Lord.
So I've kind of found that same thing. I'm like, I don't think I'm going to do well with surgery. Just from the mental standpoint, you don't want me, we're going to get ready for this, and the surgeon passed out.
Yeah. I think people don't realize what things are until they get into them. So I tell my students or potential people looking into fields, go and shadow somebody. Look at what they're doing every day, because what it looks like on paper may be extremely glamorous, but when you're actually in the setting, it's completely different.
Very much so.
Yes.
So you found optometry, went through optometry school, and now you've done a lot with your career, but you primarily are in education.
Right.
So tell us a little bit more just how you found where you're at and what you've been doing these years.
So it's interesting. When I was in my last year at ECHO, I really wanted to do a residency. I never thought I was going to teach, but I'm the kind of personality that just wanted to make the most of whatever I could. So I applied to a couple of VAs in the area and ended up doing a VA at the Brockton Medical Center on the South Shore of Boston, and had the opportunity to work with students. And believe it or not, which probably isn't a surprise, that was my favorite part of the residency, is actually working with students and watching them kind of grow, even though I was growing myself. Yeah. So I really always had it in the back of my head that I wanted to work with students, but I didn't really know the path I was going to take. So after graduating, I worked with an ophthalmology practice, and honestly, it was not what I thought it would be. It looked really, again, glamorous on paper, but they were doing everything that I wanted to do, right? I had this high level of knowledge and really couldn't use it. So I worked there for about a year, and then came down to Florida to visit my folks and met Dr. Alex Espejo, who is a professor at Nova. And we were just talking at one of these CE events, and she said, why don't you apply to teach at the school? And that was kind of the end of it. It was like, I fell right in, and it was really the best decision I ever made. I just feel like I found my place.
And are you teaching more didactic lectures? Are you more in the clinic, a little bit of both?
So we have our main campus in Davie, Florida. And so I teach the retina course at that campus in the winter semester. But my biggest passion is seeing patients in my clinic. I'm the chief of the Broward Eye Care Institute, which is in downtown Fort Lauderdale. And we see just tons and tons of pathology. So if you were to ask me where my true passion is, it's really taking care of patients. We see stuff that is in textbooks, right? The stuff that you say to yourself, why did this person wait so long? Uninsured, indigent patients, end-stage disease, so appreciative of everything that we can do for them. And I think that's why the students get such an incredible experience. So yeah, I would say I'm 75% clinician, 25% didactic. And that's a good mix.
Right.
I'm able to share my knowledge, but see patients.
I think the big component of that is that you're applying that knowledge and you're also kind of guiding the students in that respect of, look, like you have this immense knowledge, but you really have to think critically, what are we doing next for the patient? What's your decision-making process? Why?
Right.
And it ends up affecting people's lives significantly.
Yeah. And it's fun to watch them take kind of the didactic knowledge that we learned in the classroom together, sometimes if they learned it, and applying it in the clinical setting, taking, diabetes, the different classification, understanding how to apply it to the clinical setting. So that's really fun.
And I always try to the students in our clinic, I always try to emphasize, like, look, you went to school and you studied really hard for your tests, your boards. And so in your head, I know you have that mental picture of that exactly that end stage of whatever this disease was. But there's gray zones.
That's right.
Of just the subtle beginning of that you just haven't had experience seeing.
Right. And that's why optometry or any medical field is really, it is a science, but it's an art also, right? Learning to kind of play with what you learned and making the best of taking the best care of the patient. So for sure.
I'm curious how you found retina as your passion. I think there are, I've talked with a couple other colleagues and that describe it as very sexy.
Yeah.
It's intellectually sexy. I think Amanda Legge, Dr. Legge said that.
Yeah.
But for you personally, is there a personal connection to it, or is it just a fascination?
No, that's the $1 million question. I knew that I couldn't stand contact lenses because I don't have the patience to sit and try all these different trials. And interseg was just never, I don't know if I felt like I was never really good at it, but there was something intriguing about the retina. And as I did more and more of it, I just got more and more into it. And I think that really the shining light that really put me into retina was when I was introduced to OCT. Because in residency, we didn't have OCT. Everything was using your 9D, or using your gonio lens, or your macula lens, or whatever. And then I was introduced to OCT by, I don't know if you know Larry Alexander. So he was a pioneer in the retina space and very involved in OCT, and we became very close, and he got me involved in a company, and it just sparked my interest, and I started reading every article that I could, and I wanted to become the expert. And then OCT-A came out, and I'm like, oh my God, this is even better. And then I wrote a book on OCT-A, and I was like, man, this, I felt like I really found a place. So I don't know that it just kind of fell in my lap.
Yeah.
And
I think I have your book on my desk, actually.
Yeah, well, so it was like a starting book. I was proud of myself. I wanted it to be a primer for optometrists.
It definitely is, because OCT-A was just coming out when I was finishing my just standard education in optometry. And so you don't know. And then finally tools are coming out, and we're still, we're still
oh my God. And unfortunately, I don't know that it has been embraced as much as I would have loved it to be embraced. I think there's a lot of scariness to it.
Just uncertain.
Uncertainty, exactly. What am I going to miss if I don't know how to interpret it properly? I'd rather not have it, But that's the fun in it, is that I have so much work to do, And most of my lectures are on that and trying to convince our colleagues that this is the way to go, So it kind of fell in my lap.
I know OCT is a fascinating area, right? There's so much, you're like, what is that? Am I seeing this correctly?
Right.
And I'm still occasionally digging up articles that just, I'm like, I've never heard of this term. I've never heard of this like sub-classification of even macular degeneration. In fact, I was reading a publication of yours, and I'm like, oh, this is actually some stuff in here I haven't really read before.
Yeah.
So right now, I know you've been involved in some research in retina. You've done, correct me if I'm wrong, you were like maybe the head researcher for at least one study on vitreomacular adhesion.
Right. So shortly after I developed this big passion for OCT, I I went and got my master's at Nova. I was like, again, what am I going to do with myself, right? And something that I thought I could do is use OCT, and something that I would learn tons about. So I was like, oh, let me learn about the vitreoretinal space. I'm like, this could be something fun that OCT is amazing at. So one of my friends, Diana Scheckman, who no longer is at the university, we talked and we're like, yeah, let's do this project looking at, really incomplete PVD, vitreomacular traction in the population. It wasn't really well reported just because I feel like OCT wasn't, I don't know, maybe it wasn't being used as much as we could be using it. So we got a bunch of sites together around the country and we're like, let's just scan away and let's see how prevalent these conditions are. And I met some amazing people doing that. We became like the head site. And so I was able to write my thesis on that paper or that study that we did. So I wouldn't call myself a master researcher. I dabble in it. I enjoy doing it. I'm not one of these people that's into statistics. I need to get lots of help with that. I'm more of the clinician, right?
Sure.
But when it's clinically applicable like that, then it's fun and we kind of go with it.
When it comes to things like in clinic, do you find it more of the puzzle detective work that you really enjoy, or is it more of the patient interaction, education? What?
Probably a little of everything.
Okay.
I love optometry because I can sit and talk to the patient, right? I don't want to be rushed to go in and out in 30 seconds. I love one of my patients that I've seen for 20 something years are still coming back to me. That's one of the most rewarding feelings in the world. I do love being a detective, right? I love gathering the information and trying to come up with differential diagnoses. And I think that goes with educating, right? Forming lists and trying to figure out what we want to include, what we don't want to include. So I think I know optometry has been perfect for me for all those reasons, right? Because I can do all the things I love to do. I'm challenged every single day. There's new medication coming out every single day, new technology every single day. So I've been so fortunate. And I think you can tell me, I am an enthusiastic person, but I just turned 50, still at 50 years old. I'm so enthusiastic about the profession, where it's going.
Happy birthday.
So thank you. And I don't mind sharing it. That's a good thing.
With retina, there's so many sub areas, right? Yeah. And I know diabetes gets a lot of attention because it's such a big deal.
Yes.
Macular degeneration is becoming a big spotlight because of new medications that are kind of coming out. But I imagine being so involved in retina, you probably love everything. But do you have like one thing that you just love diving deep on that you've considered to be your main focus?
Yeah, I mean, I do. I like diabetes. I think that there's a lot of people out there that probably know a whole lot more than me about diabetes. AMD has been, I think, the hot topic recently, specifically because of the new medications. And really the beauty with AMD now is because multimodal imaging is so important, I really feel like I could make a mark. I can teach people because that's really where I feel like that's where my expertise lies. Right. I'm intrigued by a lot of the pathophysiologies behind these diseases, but I'm not a person I'm not an expert in congenital retina. I love the ones that we see a lot of. I feel like I've had the most opportunity to grow and learn about them. But again, multimodal imaging in AMD, using fundus autofluorescence, using OCT, using near-infrared imaging, teaching our colleagues now, because geographic atrophy was never a topic before, right? No one really...
It was just a classification.
It was a classification. So I think now there's so much education that has to be done so that we can explain to our friends, our colleagues, how we can take the best care of these patients. So that's where my emphasis is right now. I feel like next year, if something new comes out for diabetes, maybe that might, we shift. And again, that's what keeps it fun. So I wouldn't tell you that I'm married to one disease. I enjoy writing about a lot of things and learning about a lot of things.
What... certainly, like you said right now, new medications and things like that. So that's kind of where a lot of attention's at. Have you been working on any specific projects or looking into other imaging that is just, like you mentioned, infrared is something I'm not super familiar with?
So when you get an OCT scan, the regular OCT-B scan, alongside it, there's an en-face image, that black and white image. That's actually a near-infrared image. Okay. It's just a lot of different words for the same thing. So using that image, because the geographic atrophy is going to actually be white, so it's actually pretty easy to pick up. It's going to look completely different than it does on the B scan. So things like that, just teaching about what is it going to look like on fundus autofluorescence, right? And actually, it's not that difficult. It's just getting the message out there. And I don't have one particular instrument. I think that using all of them. In fact, OCT-A is probably the one that's not the most useful for geographic atrophy, even though it's the one I love the most. But OCT, FAF, again, and IR, using all these different modalities to diagnose.
So with like I guess, especially in the realm of OCT-A, and I've spoken a little bit with Dr. Carolyn Major about OCT-A. Do you have any like really great cases off the top of your head where it saved the day, made the diagnosis? Because I'd say for myself, I'm still in that zone where like we take the image and probably 80% of the time it's just like it's good information, but I haven't really been able to use it or make a diagnosis off of it. It hasn't changed my treatment in any way.
Yeah.
But there's those, again, 20% of cases once in a while. It's like I would have never seen that. I would have missed it. And so it made the diagnosis, right? It caught the disease. Do you have cases?
Yeah,
like
I would
that?
tell you that. So since the advent of OCT, and this existed before, we just never saw it because we don't do FA or ICG, but there's something called non-exudative occult neovascular membrane. So I call it NEON. It's essentially a little occult neovascular membrane that images really nicely on OCT-A, and they hide. You wouldn't even think of it when you look at an OCT scan. It's like a little blip. Maybe it looks like a drusen, and then you do the OCT-A and you can see this neovascular fronge. So we're finding these membranes now on patients that don't even meet the demographics for age-related macular degeneration. Maybe they're African American. And there's a lot of controversy on when to treat, when not to treat, but I think it's interesting to find them, refer, kind of co-manage and see what the retina specialist is going to do. But I think OCT-A shines there because, again, looking at a B scan, these things don't pop. And I show, when I do my lectures, I show the pictures of these B scans. And I said, is anyone in the room at all concerned about this B scan or this OCT? And maybe one or two hands go up because it looks like a little drusen or a little double like layer of the RPE. And yet it's a neovascular membrane. So super cool that OCT-A has been able to identify that. Right. And I would say with diabetes, there's something called diabetic macular ischemia, which you cannot see on OCT. You need angiography, so it shows this just a regular foveally vascular zone, a lot of capillary non-perfusion. So things like that B scan or OCT doesn't show us. Those would be the things where I feel like OCT-A is really needed, and that's kind of the message. Cases like this that we can't see with the modalities that we customarily use. We need to kind of think out of the box.
When you do get those sort of occult cases, these things, do you... with the retina specialists that you work with, do they also utilize OCT-A in their clinics? So you send those images and what do you think of this? Or?
Yeah, no, it's an excellent point because they laugh at me, right? They're like, I don't know what we can send them the images certainly and they'll see it. But the problem again is that most of them use FA and occult membranes don't image well with FA. So they can't find them or they don't see them. And no, they haven't embraced OCT-A as much as we have because they have FA, right? So for us, we don't have another modality. So most of them are just watching them, not doing anything. But I still feel like from a medical legal standpoint, it's nice to have them in two chairs, two opinions. And whenever I catch one, I'm like, wow. Not good for them.
It becomes a good case point and something to study and
absolutely.
potentially publish a case or a poster or something on that, just because that's how we have to push the envelope and continue learning.
Right.
I on that same regard, I think one of the challenges and why I think some people, a lot of ODs maybe shy away from retina is because it's great. We see a lot of it. We diagnose a lot of it, but a lot of it we don't currently have the ability to treat.
Yeah.
Right. Whether it be doing intravitreal injections, using retinal lasers. What are your thoughts on the status of optometry and potential future of us using these treatments?
I hope it expands. I live in a state that's, I want to say, not the most OD friendly as far as scope expansion, but I certainly believe in it. I want optometrists to be able to practice at the highest level that they feel comfortable with. I do believe that there's a place for us in this world. I don't know that we have to become surgeons or what we're not specifically trained to do, but I do believe that there is an excellent place for us, especially with the lasers and things that a lot of our colleagues are doing. But it's going to take time. We have to convince the world that we're capable and willing, able to do it properly. But I think it's great. And again, that's one of the things I love about this profession is that you can choose to do what you want to do. And it's funny. I was just talking to someone last night about retina, and they asked me the same thing. Don't you feel useless that you can't do anything? It's not like you're fitting a contact lens and I said no, because the diagnostic challenge, like we talked about that, it keeps me so intrigued, keeps me so excited. So yes, I can't treat the patient, but they always come back to me, So it's like, yeah, I sent them to, someone else for the treatment, but they're going to come back and I'm going to watch them get better, hopefully. And so I guess it's just the way you look at it.
Absolutely. Do you think if that ever became an opportunity, is that something that you would enjoy doing yourself? If let's say intravitreal injections,
absolutely,
getting training on that, and
absolutely,
it's something you
I don't know
right.
that it'll happen in my time on this earth, but but absolutely, I love to learn. I love trying new things. Whether or not it would be a thing I would do every day, I don't know, but I would love to learn.
I think that's the kind of a topic of mind, because as geographic atrophy and these new medications are coming out, it's like, yeah, but we have to give injections to do this.
Exactly.
So who knows?
But, who knows? And I think the retina specialists are probably not going to, though I know they wouldn't be happy about it because they spent years and years of training to do that type of thing. So
at the same time, I've talked with a few retina specialists who they say the opposite. They're like, I didn't go to school to do injections. To do just injections.
Yeah, that's interesting.
But again, it's
like the world. That's what makes up the world. Right.
Yeah, just as like you said, you maybe aren't in love with fitting contact lenses.
Right.
So yeah, everyone's got their.
I'm not very good at it either.
Well, I'm sure you could do it.
Maybe.
And, that's, and I think that's just a good respect to have for everybody in our professions, because some people are very skilled, whether they're just fitting a soft lens and they're their knowledge base of all the different soft lenses and the different designs of each one of those lenses, to all the way to specialty fitting of sclerals and the minutia of doing those, to being really on top of your game when it comes to using diagnostic tools for retina.
Right. That's the beauty of working at a school, because we have so many people that are excellent in so many areas that if I don't know something, there's always someone to call.
There's always someone.
So it's amazing. Right? It's a great place to be.
With being in that educational world, you've also kind of helped, I would say, coach, or you coordinated a lot with residency programs. Tell us a little bit more about kind of your involvement with residencies.
So I would say probably about, I don't know how many years it's been now, 5-10 years. I was the residency education coordinator, which basically means that I took care of inviting lecturers and guest presentations for our residents who meet every Thursday. And I absolutely love working with the residents. That's one of the kind of highlights. Students are one thing, but teaching a resident is a completely different level.
Because they're a doctor now.
They're a doctor. They understand. You can take it to a higher level. That's why I love continuing education, right? Because it's a completely different level of education. But so just bringing in local experts, even just faculty that have different areas of expertise. So I coordinated Residence Day, where all the residents would give a public lecture or continuing education. So watching them grow was amazing. And I'm still very involved with the residents, not at that level, but in the clinic. And I run something through the Optometric Retina Society. We do a resident case report contest every year. So we have organizations that give money, and we have residents submit papers, and we choose a retina-related manuscript, and actually Review of Optometry publishes it for us. So I still am very involved with the residents and making sure that they have an amazing experience. So I kind of missed that, but that was another chapter, and so now we move on to the next thing, and so that was.
I think residency was very valuable for myself, and I've talked with a few other professionals, and it seems like I've never met anybody who says they regret doing a residency. I know that is a topic of concern and interest for some doctors in our profession, because it seems like it waxes and wanes. Like new doctors' interest in doing a residency. But what are your thoughts on our profession going forward? Do you think residency would ever be almost, I guess even in medicine, it's not required.
Right.
But it's kind of required.
Right. No, agreed.
For practice, anyway.
Yeah.
How do you think that will ever apply or change to optometry?
So, when I speak to students, some of our top students, and I ask them, are you going to do a residency? Hopefully some of them say yes. I would say that the ones that say no, it's because of the monetary part of it. I think that obviously they don't get paid very much and they have a lot of debt. I think that the majority of students, if it was free, would say, yeah, I would. I'm not the majority, but I think you'd get a good amount that would say I would do it, right? Not, or get paid a good amount is what I mean. That's not free. You know what I mean?
I had to reverse it.
Exactly, right. I messed that up. But I would love for every student to do a residency. I mean, obviously there's not enough of them, But my hope for the profession is that everybody practices at the highest level. And I feel like the way that we achieve that is by education, right? So like you said, nobody regrets it. I think jumping in and saying, okay, I'm going to like take a year or I'm going to live as a student again might be a little, no one wants to do that. But in the end, it's worth buckets and buckets that you can't get back if you don't do it. So I would hope that everyone would embrace it. It's not going to happen. And I don't know that it's ever going to become mandatory. I can't imagine it would, because we're not going to have enough programs to support that.
Yeah.
But I'm a huge proponent of residencies. I mean, it's a year of personal maturation and growth, right?
And you said you did your residency at the VA.
At a VA, yeah, hospital-based optometry.
Right.
That was a crazy year. Right? Talk about seeing, really elderly sick patients who, but super appreciative.
Yeah.
Our vets are really one in a million, but you have to be the right person for that.
I always try to people who are not in our industry, and I have to explain what my residency was like. Or
what was yours in?
So it was also at the VA.
Okay.
And I'd always try to tell people, it's like, well, in school you learn one disease at a time. And then when you are in residency, you're seeing very challenging cases that are not just one disease at a time.
That's right.
You're seeing 4 diseases at a time. And that's just the eye. They also have 8 other systemic diseases going on, and they're on 200 medications that all interact differently. And so then you need to make not only a decision about a long-term chronic disease in one part of the eye, but you also need to manage the acute high IOP issue that the patient has right now.
That's right.
And you can't tell, is that because of angle closure? You have to figure out what's causing it. You have to make that decision right now because you have 12 more patients who are ready to be seen, and you have to call the shots on that.
Yeah.
Or if you see an emergency going on in their eye, like you see a Hollenhorst plaque or something like that, you're the one who's got to make that call of, okay, I've got to send them to go get a carotid ultrasound. I've got to call the vascular surgeon on call because the carotid ultrasound was only like 98% blocked. And so you develop tough skin, but you also, and I think the first 3 months.
I was just going to say, I'm surprised I survived the first 6 months. It was really, really challenging. I didn't know that I would make it.
There were, I'll be honest, there were days when I left, I was exhausted, mentally fatigued, emotionally beaten, because I felt I was not just underperforming, but you feel stupid. You realize how much you don't know.
You're describing my exact experience. I mean, it was really, it was humiliating. I came out of 4th year, I felt like a rock star, like this girl's going to kill it. And then I show up and I'm like, it was humiliating, right? I mean, the doctor I worked with knew every name off the top of his head, and he would ask me, did you follow up with Mr. Jones? No. I have so much to do. Like, that's the last thing. But you bring up a good point. It teaches you how to approach a case, right? You have a case with so much complexity, and if I hadn't gone to that last year, that residency year, I would have been totally overwhelmed. You have to learn what to weed in, what to weed out, what to pay attention to, what to not pay attention to. And I think it gives you a way of critical thinking that you can't get when you're so caught up in, can I even get a view with 90, right? Just takes your level your education to a different level. So I wouldn't take that year away for anything, even though I'm surprised I made it. But
I just realized people who are listening to this, if they're a student, they're like, we're not
doing
selling the residency to them at all. The other thing, and I'm trying to always even mention this to the students at our clinic, I'll ask them, why are you making that decision? Like, why do you want to treat their pressure today when it's 28?
Right.
And they're all, a lot of times, and I think we're all at that stage, we all hit that stage, well, it's because that's what I learned in class.
That's right.
And I'm like, that's great that you learned that in class, but
where's the substantive?
But where did they come up with that?
Right.
What evidence do they have to guide that? And then they'll be like, the OAT study. I'm like, okay, what did the OAT study say?
Let me go back to my notes.
Have you read that?
Right.
Oh, no. Okay.
Right.
Do you think maybe you should read that? How about we discuss that tomorrow?
Right, exactly. And that's being put on the spot like that is what makes you better, right? Because I'll never forget the things that I messed up on when I was there, and I will remember them to this day because you feel this big, right?
Yeah.
So it's an amazing learning experience. It toughens you up. It makes you ready for that. And I say to the students, when you go out into the real world, it's going to be easy, Right? We hope. I don't know if that's true or not.
You still get those cases.
Yes, you do, but not everyone.
Yeah,
right?
And you're also not like completely like a ghost, white as a ghost when you see that case. You're like, oh, well, I know what I can do today.
Exactly.
And I know who to call, or I know at least the next logical step.
Exactly. You know how to approach it, which is worth everything.
Right.
Instead of freaking out. You might not know what it is, but you know what to do. Right?
So back to kind of what you're working on. Do you have any big projects, anything coming up, or are you just focused on seeing patients in the clinic, helping the students, writing CE? What's going on?
So I'm actually working on 2 different studies that hopefully will start when I get back. I'm waiting for some IRB paperwork. But one of them was we're going to be looking at geographic atrophy using 2 different imaging modalities. We're going to use Optos and the ADEN, which is another wide field unit. I'm not sure if you're familiar, but I'm curious how these wide field imaging modalities capture posterior pole pathology. And I want to kind of compare just to see the intricate details of the photo, just for myself because I'm interested. So it's kind of just a side little one. The other one is I do a lot of work with LKC, which is a company that has put out a handheld electrodiagnostics unit.
We use LKC's ERG.
Yeah. So as you probably know, it's a functional test, right? We're testing the functional integrity of the retina. So I want to look at my results with that unit versus OCT-A. And I want to see, does one of them do a better job at identifying early functional loss? Do they correlate with each other? So I'm super excited about that. There was only one other paper written on that topic. We're going to look specifically at diabetics, all diabetics, just to see how the different functional tests kind of work with each other.
That's interesting to me. I look forward to seeing something about that.
Yeah. So again, I'm not a huge researcher, but kind of taking clinical application and riding with it and seeing if we can make expand our knowledge on it.
Right. And I think that's at least my experience with some of the ERGs. I'm always, and it's with all testing, we learn how important reliability is.
Right.
And so I'm always a little questioning, like, is this reduction that I'm seeing, is that a true finding, or is it because the technician or the student didn't place the eyelid, like the sensor correctly? Because I'm like, this is a big difference between the right and the left eye.
Yeah.
Is this really that significant?
And Joey, that's an excellent point because with OCT-A, there's a lot of artifact involved. Poor tear film quality, dry eye, cataract. All of those things can affect the quality of the image. And a lot of times you'll look at the image and say, well, it looks like this patient has, widespread capillary non-perfusion, when really it was just a dry eye. Yeah. So I think that's what we were talking about much earlier, is understanding when you need to worry or what you're seeing is actually a problem and not something. So yes, that's a very valid point, and kind of need to thread through the patients and take out the ones that are going to mess up your your study.
Which is a challenge, and I've had some experience with that when I was a student. But I think that's a huge one of the most valuable things I've read in either people's publications is learning to identify acquisition errors.
Yes.
Especially in the OCT world, you're like, oh, look at this. This is all messed up. This is reduced.
Right.
This must
it's
be
just a bad scan.
Yeah, this is bad. This must be glaucoma. I'm like, no, but look up here. There's even though you got a 7 out of 10, like this person's eye is moving constantly. You're not even looking at the right spot in the retina anymore.
Right.
So then all your data is thrown off, and of course it's going to
Right.
come off and be flagged as being poor.
And that's, I guess, just like if you're in the contact lens world, what works, what doesn't work, and it just becomes part of what you do. But yeah, those are some of the fears that people have with these technologies is, what's real, what's an artifact, but we'll see what happens. It should be a good study, so I'm excited to go with it.
It remind me once again, the first project you're working on, you said?
So geographic atrophy.
The geographic atrophy.
We know that using just, posterior pole images will be phenomenal.
Yeah.
Or they'll do a really good job at imaging geographic atrophy. And it's not just with GA in general, how do these wide field imaging modalities do at capturing posterior pole pathology? Specifically if you're looking at grading AMD, right? We know we're looking at drusen size, we're looking for pigmentary changes. I feel like sometimes when you have a really big picture, you lose some of those minuscule details that I think are really integral in making the diagnosis. Yeah. So I'm curious, just because I've seen myself a lot of differences in the technologies, how are they going to compare? Which one's going to do a better job at picking up these really not even, the study's GA, but looking specifically at, any disease process.
Yeah. And I think that's just the knowledge of
a really wide field lens and that type of
Yes.
imaging
Yes.
is that it's great because you can see so far out in the periphery, which
Right.
is a huge challenge otherwise, but there's no optical zoom, like all the zooming that you're doing in
You
toward
get
the macula.
blurry when you...
It does get blurry, and that's because it's a digital zoom.
Right.
And so you're really stretching out that image,
Right.
and so things become pixelated. And so it will be fascinating to see how that technology improves. Are they going to include an optical zoom imaging in the center macula somehow?
I would love that.
Because then being able to really telescope in and out and
Right.
see the level of detail, or, and I definitely see this, but some level of AI processing, like
Yeah, that's definitely gonna
software
happen.
processing, because that's where a lot of phones are going.
Yeah.
If you're into the tech world, like Google just announced their new like Pixel whatever, it has so many levels of software
Yeah.
that's constantly processing every image you take to be able to adjust and change change the level of detail, color, and to maximize it for like the
I
human
think
eye.
that's definitely on the horizon. I mean, I think AI is gonna... I'm not a professional in that realm at all, but I think that's definitely gonna take over a lot of what we do every day.
Yep.
But it would be amazing if these wide field, cameras had that capability, because let's be honest, most optometrists own a wide field device, whether or not they're using it. I would hate to say substituting it for dilating, but most doctors do have that. How many have an actual just fundus camera where you're looking specifically at the posterior pole? I don't know if there would be as many. I mean, I don't know these statistics, but I know a lot of people have wide field cameras, and so I think that one of the things that's happening is we're not diagnosing enough or well enough because we're relying so much on these imaging modalities, or at least
I think that it can be argued either direction. I think there's some modalities where they're seeing many patients in a day very quickly.
Yes.
And maybe even for that doctor, their skill set isn't the best at doing really detailed DFE.
Correct.
Maybe they don't feel comfortable doing even things like scleral depression. So I think in those cases, they are super valuable in
100%.
that they help identify.
100%.
But at the same time, I still personally believe dilation is still a standard. I know I get better views of the central macula behind my steady good view with a 78 or 90 than I do with images of wide field. But then again,
you're
there's
100%
a pro and con
right.
for each direction.
I think it's just a matter of everyone knowing their limitations and knowing what they can and can't do, and referring if appropriate, or referring if if they're not sure.
But then patient education.
Oh yeah, absolutely.
That's where it shines the most,
Absolutely.
right? Just getting a patient to understand what you're seeing, the value of coming in, what you do. Then of course,
that's where we shine. That's this profession, right? That's where we shine.
Because you can't. The normal people can't just see their eye. It's a part of them that you've never really known yourself.
That's right. It's neglected. It's actually interesting. I have two daughters who both want to be medical doctors, and they told me straight out, Mom, we're not doing ophthalmology. We don't like the eye. We don't like physics. We don't like any of that stuff. So don't harass us. And it makes me so sad because I'm like, you guys don't know what you're missing. I mean, this is like super exciting stuff, but they want to do peds, and I could never be a pediatrician. I'm like, okay, you guys do peds, and I'll stick with the eye.
They've got time to explore and realize maybe they don't want to do peds.
Right. Maybe as they go through the program, things will change, and they'll, maybe can you imagine they might come back and say, Mom, we changed our minds.
Who knows? I
mean, that ophthalmology is one of the hardest residencies to place into.
It's
one of the most competitive residencies.
And do you think it's purely academic? Is it skill set?
I think it's lifestyle.
Lifestyle?
I think that unless you're like in a surgical ER or something, I think ophthalmology is pretty good field to be in.
Right. And I think kind of like in optometry, for most optometrists, we have the opportunity to work normal hours.
Yeah.
Not necessarily be on call at 4 a.m. to go do an emergency sort of thing. Although there are those cases.
But I'll tell you, some of my favorite memories, although of my residency, which was really, like I said, a crazy year, was those on-call emergencies, right? Those are the ones where you're just really learning and getting into the nitty-gritty, right?
It turns out to be just astigmatism.
Yeah, right. You have a dry eye. But some of the stuff that came in was just wild.
Right. Like injuries.
Injuries. Right. I mean, sudden onset retinal detachments, things that,
sudden vision loss.
Sudden vision loss, yeah. So it's good stuff.
Well, Julie, thank you so much for being here and sharing so much insight into what you do, what you give a damn about. From my most gratitude. Thank you so much for spending some time with us. And I hope that you have nothing but great success with your new projects coming up. And I look forward to seeing your publication.
And Joey, you're amazing. Just so you know, you've done an amazing job with this with this podcast and continuing to elevate our profession. So thank you.
Thank you.
So that was our episode for today. Thank you so much for tuning in. If you did find value in this episode and like to hear more, make sure to subscribe to us either on YouTube or follow us on wherever you get your podcasts from. Otherwise, I appreciate you guys listening in and hope you have a fantastic